Spinal Manipulative Therapy for Low Back Pain, a guideline from the Canadian Chiropractic Guideline Initiative. Let's review some perspectives on chronic low back pain. In 2015, musculoskeletal disorders were the largest contributor to global years lived with disability, 18.5% of all YLDs. Approximately half of these are due to low back pain. A nearly threefold increase in the prevalence of chronic low back pain was observed between 1992 and 2006, now affecting more than 630 million people. Chronic low back pain is associated with significant comorbidities, including diabetes, coronary heart disease, and depression. Approximately 90% of all low back pain cases are nonspecific in nature, meaning the pain cannot be attributed to any specific pathology of the spine. In fact, only about 5% of low back pain cases are due to nerve root compression, such as a prolapsed lumbar disc, spinal stenosis, or surgical scarring. It's no surprise, then, that there have been decades of attempts at classifying low back pain, studying various treatment approaches, and developing clinical approaches that are more effective. One such approach is a recent guideline developed in Canada. The title of the publication is Spinal Manipulative Therapy and Other Conservative Treatments for Low Back Pain, a guideline from the Canadian Chiropractic Guideline Initiative. This was published in the Journal of Manipulative and Physiological Therapeutics in 2018. The researchers state, quote, "The primary aim of the clinical practice guideline was to synthesize and disseminate the best available evidence on the initial assessment and monitoring of people with low back pain and the use of spinal manipulative therapy alone or in combination with other conservative treatments for adults and elderly patients with acute and chronic back pain and back-related leg pain, with the goal of improving clinical decision-making and the delivery of care for patients presenting with a Class 1 through 3 pattern," unquote. We'll discuss this classification approach soon. The guidelines were developed by a panel. This panel represented a wide stakeholder involvement with members who were clinicians, clinician researchers, methodologists, a professional leader, and a patient advocate. The topic areas were chosen based on an Agency for Healthcare Research and Quality Comparative Effectiveness Review, which was based on the standard PICO format: population, intervention, comparator, and outcome. The comparator in this guideline review is a conservative treatment that may include non-pharmacological approaches, such as physical and psychological therapies as first-line treatments or usual medical care. It should be stated, though, that no studies comparing SMT and psychological treatments was found. The quality of each study was rated using the AmStar tool and the Cochrane Back Review Group criteria. Researchers used the Global Spine Care Initiative classification system for spine pain, classes 1 through 5. With Class 1, the patient has mild symptoms, Class 2, moderate to severe symptoms with no neurological deficits, and Class 3 with neurologic symptoms or deficits and local pathology compressing neural tissue and affecting activities of daily living. Inclusion grades were Class 1 through 3, including the subgroups which are based on acuteness and severity. Exclusion criteria were people under the age of 18 and those presenting with possible spinal stenosis or a Class 4 or 5 pattern, in other words, stable but severe deformity or serious or systemic pathology, respectively. Researchers first present recommendations on the assessment and monitoring of acute and chronic low back pain and back and leg pain based on current guidelines. There are 10 recommendations, which include a patient-centered focus, considering the patient's context, a problem-focused exam with a search for red flags, and a screen for risk of prolonged recovery using, for example, the Start Back Screening tool or the Orebro Musculoskeletal Pain Screening Questionnaire for detecting psychosocial factors that might be relevant in patient care. They also recommend using the Global Spine Care Initiative classification for low back pain, consider using new patient functional outcome electronic data collection systems, and avoid diagnostic imaging unless searching for serious pathology. Next, the researchers condensed down 10 initial clinical questions to 5 due to overlap in the types of clinical comparison. Let's review briefly each of the 5 with a bulleted summary of their findings and recommendations. Note the significantly small number of randomized controlled trials that qualified for use in these guideline recommendations. Number 1, should spinal manipulation versus another treatment be used for acute or subacute low back pain? There were only 2 randomized controlled trials. In the Fritz et al. Trial, only disability improved after 4 weeks when comparing early physical therapy with spinal manipulative therapy compared to usual care. In the Brennan et al. Study, patients matched to manipulation, stabilization, exercise, or specific exercise had less disability in the short term compared to those not matched to specific management. The researchers state in summary that for patients with acute low back pain, they suggest spinal manipulative therapy, other commonly used treatments, or a combination of SMT and commonly used treatments to decrease pain and disability in the short term based on patient preference and practitioner experience, with a low quality of evidence and a conditional recommendation. Number 2, should spinal manipulation versus inactive treatment be used for chronic low back pain greater than 3 months? There were 3 randomized controlled trials that qualified. In the Haas et al. Trial, modest improvements in pain and disability were observed in SMT groups more frequently treated, receiving either 12 or 18 sessions of SMT over 6 weeks. In the Gibson et al. Trial, statistically non-significant reduction in pain was observed at 1 and 3 months following SMT treatment compared with detuned shortwave diathermy. In the Balthazard et al. Trial, the SMT plus specific active exercise group had lower disability at 6 months compared to detuned ultrasound with active exercise. The researchers state in summary that for patients with chronic low back pain, they suggest SMT over minimal intervention to decrease pain and disability in the short term, with very low evidence and a conditional recommendation. Number 3, should spinal manipulation versus another treatment be used for chronic low back pain? There were 3 randomized controlled trials. In the Shia et al., both SMT and non-thrust spinal manipulation reduced pain compared with the control group, respectively. However, no difference in outcomes was observed between SMT and non-thrust spinal manipulation, which was, in this study, flexion traction. In the Carlos Sanchez et al. Trial, an SMT group demonstrated lower disability immediately post-treatment and at 1 month compared to a low-force functional technique not described in this guideline. And in the Ferreira et al. Trial, motor control exercise and SMT produced slightly better short-term function and perceptions of effect than general exercise. The researchers state in summary that for patients with chronic low back pain, they recommend SMT or other treatments for short-term reduction in pain and disability with a high quality of evidence and a conditional recommendation. Number 4, should spinal manipulation plus other treatments versus other treatments alone be used for chronic low back pain? There were 5 randomized controlled trials. In 4 of these, multimodal therapy consisting of SMT plus another treatment was as effective as treatment without manipulation for pain at 1, 3, 6, and 12 months, with similar effects for disability. A 5th RCT by Gertz et al. Evaluated the effectiveness of SMT plus standard medical care compared with standard medical care alone in improving pain and function. Spinal manipulative therapy plus standard medical care was more effective than standard medical care alone for reducing pain at 1 and 2 months and reducing disability at 2 weeks and 1 month. The researchers state in summary that for patients with chronic low back pain, they suggest multimodal therapy with or without SMT to decrease pain and disability with moderate quality of evidence and a conditional recommendation. And number 5, should spinal manipulation plus other treatments versus another treatment alone be used for back-related leg pain, in other words, sciatica or radicular low back pain? There was 1 controlled pragmatic trial by Bronford et al. Included. SMT plus home exercise and advice was associated with reduced back and leg pain and disability at 12 weeks compared with home exercise and advice alone. However, only global improvement, satisfaction, and medication use had sustained improvements at 52 weeks. The researchers state in summary that for patients with chronic back-related leg pain, they suggest SMT plus home exercise and advice to reduce back pain and disability, with a low quality of evidence and a conditional recommendation. So let me summarize the recommendations with some observations. Many of the studies were rated as low-level evidence with minimal effects compared to other approaches. Many of the recommendations were based on a conditional recommendation based on the low level of evidence. Recommendations seem more based on the observation that SMT is a safer approach, in other words, fewer adverse events, compared to pharmacological approaches. In general, this set of guidelines agrees with many recent guideline approaches, recommending that the patient remain active and that a multimodal approach seems to have the most evidence of effect. And although nothing really new is being stated or recommended, it does provide one more opportunity to educate not only clinicians who deal with spinal pain, but also policymakers and third-party payers about spinal manipulative therapy as an option for low back pain patients.